I would like to give a brief introduction of Dr. Rishikesh Mai, who is our chief instructor for this course. He's the director of Avdut Netralay at Nagpur. Prior to that, he was a consultant at Eye Hospital and Center for Sight in New Delhi. His post-graduation and fellowship in pediatric ophthalmology and strabismus is from Shankar Netralay, Chennai. And he's won many awards on a state and national level for his work in strabismus, including a best poster podium presentation at AIOC last year and a best paper at the Bombay Ophthalmologist Association. Dr. Rishikesh Mai is going to be speaking to us. Basically, we are talking about causes of unexplained vision loss. So he's going to be speaking about hereditary retinal disorders when we evaluate the child and the eye essentially appears normal, including the fundus.
Thank you, Dr. Varshini, and thank you for all the speakers for joining this particular instruction course. So I'll be covering the hereditary retinal disorders in a normal looking retina. I'll start with a couple of cases. 8-year-old male who presented with a history of decreased vision since early childhood. His father also had a similar history in the first decade of life, and the patient was actually started somewhere else on alternate patching. If there is a difference in vision in the two eyes, patching is what we normally resort to if there is no known cause of decreased vision. But remember that he had a family history of decreased vision as well. So his visual acuity actually in both eyes was N36. I don't know how alternate patching works because I hardly do alternate patching nowadays. The rest of the anterior segment examination was normal, and apparently the fundus examination also looked normal. But on closer look, you will see that the patient had a bilateral optic atrophy, which is one of the commonest hereditary optic neuropathies to cause decreased vision. Second patient with a 9-year-old male who presented with decreased vision in the left eye since 3 years, and there apparently, there was no other cause of decreased vision. He was started on patching. There was no anisometropia, no strabismus, but the vision in the left eye was 6/60. So probably it was not amblyopia, there was something else which we are dealing with. Apparently again, the fundus looked normal in the right eye as well as the left eye, but on closer look you will see that the patient had a demarcating line here, and something was not correct about the optic disc. So we decided to do a angiography for this patient, and we found that he had optic disc pit. Along with that, he has a serous retinal detachment, and that is probably the reason why the patient was not responding to the patching treatment. So why one should know about hereditary retinal or optic nerve disorders are because many of them actually present with normal fundus, and family history may not always be present. So we really have to find out what is the cause of decreased vision in these cases, and because once we know the cause, we can help the patient and the parents in counseling. We can give palliative treatments like low vision aids and appropriate lifestyle changes or modifications so that the patient's academic and social skills or social performance improves with time. So not everything is lost if we cannot diagnose what is the cause of decreased vision actually. So important symptoms which one should remember is that patient may have photophobia and nystagmus. Think in terms of these three as the cause of decreased vision. Night blindness can be retinitis pigmentosa or stationary night blindness. History of eye poking or oculodigital reflex and also mental subnormality can indicate case of a Leber's congenital amaurosis. As in this case, she had not much of a neck holding. She's I think around 2 years of age, and you can see that she has mental subnormality and hardly she is looking at anything specific. She has nystagmoid movement, and she is trying to move the eyeball up because that is the source of light, and they always search for light in these cases. Oculocutaneous albinism may not be always normal. Not easily diagnosed. At times it can be a subtle feature, and the patient might have pendular nystagmus, which you should not rule out. Photophobia is something which is classically seen but not always present, depending upon the kind of depigmentation or lack of pigmentation the child has. So also look for certain behavioral patterns, like in this child you can see that just the behavior shows that he is trying to look or force his vision for near objects. So definitely the vision in the both the eyes is less. Or this child with a bit of, she has a mental subnormality, and again she is trying to fixate at objects which have been shown. The vision is not gone, but definitely it is less than what a normal child's vision should be. So important signs can be high hyperopia, which indicates LCA, or high myopia can be associated with CSNB. We have also found that albinism has astigmatism as most common refractive error, or a nystagmoid movement in a child which I just showed, or a patient with, I mean, look for other systemic features like this patient with obesity. He is 5-year-old. Along with that, he has got a polydactyly, which is a case of a Bardet-Biedl syndrome, which is associated with hereditary retinal dystrophies. So points which need to consider is how is the fundus, how is the visual loss, it is progressive or stationary, and what is the extent of visual impairment, whether it is mild, moderate, severe, or almost near complete blindness. It can, I mean, the hereditary retinal disorders can be with an apparently normal looking retina, and these are the usual cases which present with severe visual loss but a normal looking retina, or it can be with normal looking retina, or it can be with certain conditions where certain retinal pathologies will be seen. It can be a non-progressive condition where, like in stationary night blindness or albinism, where the vision reduces but not beyond a certain extent, or it can be progressive and lead to blindness, like case of retinitis pigmentosa or a case of a cone dystrophy. It can be a moderate visual impairment, like in case of a Stargardt's disease, which is very common. I think everybody must have seen in their clinical practice, or a case of retinoschisis or albinism, or it can be with profound visual impairment like retinitis pigmentosa, LCA, or CSNB with high myopia. Certain cases of pattern dystrophies and cone dystrophy also will present with profound visual impairment. I will just share some profile which are very classical for certain kind of retinal dystrophies, which will give a clue to the diagnosis itself. Patient with first or second decade of life with family history of decreased vision. He started having decreased vision, progressive visual loss at late first or second decade with a normal looking fundus. Apparently this fundus looks normal, but you have to look closer. Family history is something which will give a clue that you will see a bit of beaten metal appearance, which shows that it is a case of Stargardt's disease. You may not have this feature, but a family history with a patient having decreased vision in second decade of life, always get a FFA done, because you will get a silent choroid, which indicates that this is a case of a Stargardt disease. Stargardt disease is usually autosomal recessive, and it will have progressive visual loss till 660 or counting finger, but it never leads to blindness. Treatment can be vitamin A supplementation and also low vision aids. Another patient profile, normal looking retina, but patient has night blindness, and if you look closer, you will see that there is narrowing of the retinal vessels as seen here, which might be an early sign of retinitis pigmentosa. Not all kind of retinitis pigmentosa will appear like this, because many times it may be that the pigmentary changes will not be seen. So even the optic disc pallor or waxy pallor of disc, which has been described, appears later in life. So retinitis pigmentosa is a progressive condition which lead to peripheral tunnel vision, certain systemic association like Bardet-Biedl syndrome I have already mentioned, and there is not much treatment, but we can explain the progressive visual loss in these children. Another patient with night blindness with family history of night blindness, but a normal looking fundus and a non-progressive visual field loss. He has a high myopia, and this is very typical. Most of the fundus features are similar to what you get in high myope, but night blindness with myopia usually indicates a severe type of CSNB, where the visual outcome is really poor. If it is without myopia, then perhaps the visual outcome is better. Coming to another patient with profile of photophobia with pendular nystagmus. When you have this, you think only in terms of three conditions. Either it can be cone dystrophy, or it can be aniridia, or it can be albinism. You can have a milder form of albinism where the fundus will show some amount of tessellation here in the mid periphery, whereas the macula looks normal. But in severe cases, you will have this appearance. So albinism is a autosomal recessive or X-linked condition. Photophobia is what patient will have, and a pendular nystagmus. Usually the cause of decreased vision is hypoplasia of the fovea and the optic nerve head. Their systemic associations are also have been mentioned, and the treatment is tinted glasses. Usually the vision is 660 or counting finger, and it doesn't progress to complete blindness. Another patient profile is a photophobia with nystagmus, and she sees better in bright light. It sees better in dim light compared to bright, because it doesn't tolerate the light well. Again, a case of photophobia with nystagmus, and the second diagnosis which I told you is a cone dystrophy. Cone dystrophy in the earlier feature, in the initial stages, will appear like a normal fundus only. It is only in advanced cases that you will see something like this. This is, we call it as a bullseye maculopathy, and very rarely you will see in clinical practice. Most of the cases will be at this stage only. So these patients' presentation can be varied from first to sixth decade of life, and they will have progressive visual loss with intact peripheral vision, and the fundus appears normal. As I just mentioned, treatment is vitamin supplements and omega-3 fatty acids. Another patient profile, history of distorted vision and scotomas, and the patient has no photophobia or night blindness, and the fundus picture in the initial stages is normal, but in advanced stages you will have something like this, which is called Best vitelliform dystrophy. In the initial phases, we called it as Best disease, which appears in earlier onset, first or second decade of life. What I showed you was in later on in life. Okay, usually it doesn't progress to complete visual loss. Another patient profile is first or second, patient has decreased vision in first or second decade of life, and usually males are affected. The fundus actually appears normal, but on closer you look, you will see that there is some amount of macular edema kind of picture in the macula. If you see something like this, get a scan done, and OCT will actually help in these cases. This is basically a case of a retinoschisis, X-linked retinoschisis. Because it is X-linked, males are more likely to be affected in the second decade of life. Usually it is not a progressive condition. More important, you need to explain to the patient that trauma needs to be avoided, because a minor trauma can lead to retinal detachment. Treatment has been described with carbonic anhydrase inhibitors. There are various ERG patterns. Access to ERG may not be available in many of the places, but you need to know what kind of pattern you are able to see. So more important is when you see something like cone dystrophy, the photopic response is gone. And in case of stationary night blindness, if it is associated with myopia, you will have something like a negative waveform. Something like retinitis pigmentosa or something like advanced case of CSNB will have a flat pattern in most of the types of photopic as well as scotopic pattern. This I will skip. Just one last case. Patient was a male, and apparently normal looking retina with sudden visual loss in second decade of life. No family history, and you can see that he is a male with sudden loss of vision second decade. On closer look, you will see that there is retinal vessel tortuosity in the peripapillary area, whereas in the periphery it is normal. This is seen in the earlier stages of Leber's hereditary optic neuropathy. It's not as rare as you think. I have seen 3 cases so far in last 6 years. So field examination will show field loss. Because it is mitochondrial inheritance, males are affected. So with this, I would like to conclude that hereditary retinal disorders is an important cause of visual impairment with normal looking retina, and look for proper history, family history, systemic features as well as ocular features in these cases, and you need to diagnose and explain that the patient the condition, so that not only it helps in changing the lifestyle of the patient, but also helps in better visual outcome, and in terms of academic as well as a professional it will help the patient a lot. With this, I will invite you for the midterm conference of Strabismus and Pediatric Ophthalmology Society, which is scheduled in 19th of June in Nagpur. Thank you.
It's a wonderful presentation, Dr. MRC. I just had one comment.
Yeah.
So, since you said mostly we need an FFA to diagnose some of the conditions, but I feel that since we have the fundus autofluorescence photograph which has come, in children it's become like much easier to diagnose some of the simple conditions, especially Stargardt's, because Stargardt's is like an instant diagnosis on a fundus autofluorescence, whereas of course doing an FFA in a 8-year-old is problematic. And ERGs, of course, as you said, clinically, normally we can localize the patients to a particular group, and an ERG really helps in confirming the diagnosis and then prognosticating, because from an educational assistance point of view, parents and the children, they really need to know, how much assistance they are going to require in education. Thank you so
ERG,
much.
Before sending the patient to ERG itself, you should
Yes,
predict
yes,
the
yes.
condition. Don't depend
Definitely.
upon ERG for the diagnosis.
Definitely.
Because that will help in proper counseling of the patient.
In fact, even in very younger children, when we have to do an ERG under GA, if the features are very typical, you can even delay the ERG.
Yeah.
Because you're not really going to, especially as you're saying in cone dystrophy and all, you know the diagnosis. So there's no particular point in subjecting a child to a GA only for that.
I think ERG I would more rely for the CSNB,
Yeah.
because
Yeah.
I want to tell them that it's a stationary disease. So ERG really helps that. Because otherwise, if it's a night blindness and you want to say that, oh, it's a progressive disease or stationary. So if it's a progressive disease, parents are, frightened like, oh God, it's an RP or cone dystrophy, which is progressive. So CSNB, if you tell them, of course, it is not progressive, I think it really helps.
For obvious cases like RP or cone dystrophy, perhaps you may not do a ERG actually, because they are very obvious cases. But just for academic interest, I had to show that. Thank you. With this, I would like to invite Dr. Suma madam for her presentation. I think she doesn't need any introduction. She is the in charge of pediatric ophthalmology department, and she has done extensive work in the field, and all of us have been beneficiaries of that of her work. So I'll invite Dr. Suma. You can go back here.
ये वाला ना? Second. I think, Vashti, can you give any tips of ERG and VP in children, like, how to, because most of these conditions, maybe you can, you need to do a ERG and VP in children. Any tips you can give to all of us?
So generally what we are looking at is a full field ERG. So basically we need to clinically first decide whether it is a retinal problem or it is an optic nerve related problem. So if it is an optic nerve related problem, we usually see the disc pallor and nystagmus. If it is present since birth, associated with the poor vision, along with a very normal looking retina. So we usually go for imaging first to see if there is any cause of optic atrophy, especially since, as ma'am will detail for us, CVI is so common. So if the imaging is normal, VEP generally can be avoided in most of the infants if we see a disc pallor, because we are not getting, a lot of children we get referred for VEP, but if you see a disc pallor and your imaging is normal, your VEP is not adding anything whatsoever. So subjecting the child to an unnecessary general anesthesia is really not required. The pallor, what we can see clinically, 90% of the things we can diagnose clinically and don't require further evaluation. Where we actually require the VEP is when the fundus looks absolutely normal and you're really not sure whether you can localize it to a macular pathology or an optic nerve pathology. Or you get a sluggish reaction of the pupil, the disc looks absolutely normal, and you want to decide whether to go in for an imaging or not. So you want to confirm that it is an optic nerve pathology. So generally these are things like compressive optic neuropathies, these are things like toxic optic neuropathies, like an early ethambutol toxicity where your fundus nerve, everything looks normal. Maximum you may get a sluggish reaction of the pupil, or a bilateral optic neuritis which is presenting suddenly. So those are the conditions where the disc actually looks normal is where I would go in for a VEP, not where I can see a pallor. Because if I can see a pallor, I know the VEP is just going to show me a delayed latency with maybe a reduced amplitude that you can see from the fundus itself. Where the ERG is required is again to confirm, as ma'am said, the particular diagnosis. So if we have this constellation of features suggesting a Leber's congenital amaurosis, I still want to confirm the Leber's because it has a lot of systemic associations. There are treatments available for some genetic forms, so we want to send the patient for a genetic evaluation. So we want a confirmation of the diagnosis. If it is a cone dystrophy, again, some of the conditions, some of the variants of cone dystrophy are progressive. So we do want a diagnosis so that, again, from an education point of view, we can counsel, we can certify the patients, and there are many low vision aids now to help them with their education. So we do want a diagnosis. In CSNB with a normal fundus, again CSNB presents with two variants, normal fundus and an abnormal fundus. So if you have an Oguchi or a fundus albipunctatus, that is a reasonably clear-cut diagnosis. So if you don't have access to a ERG, if you have the subnormal vision, difficulty in night blindness, and a typical fundus feature, ERG is not essential. But if you have a CSNB with an absolutely normal fundus, then definitely it's a non-progressive benign condition, and we do want to get that ERG done. So generally ERG is to confirm our diagnosis and as to how we are going to move forward. And most of the diagnosis part can be done clinically itself, just by looking at the constellation of clinical features.